Hello, people. Not too many people here yet. That's okay. Gonna take a quick roll. If you know that's worth some points. Go ahead, lay down, buddy. Okay, people. Too many people here yet. Better show up soon. Class starts at 12:30. And I think we've got Sandra Stange up first, if I'm not wrong. New Amy shows. Yay, new Amy. Dante. There's Audra. Hi, Audra. Saltange. Simmons is here. And life is good. Sammy Robinson shows up, which is good because he's talking today too. Cole Salazar. Welcome, Cole. Somebody left. Okay, we're still waiting for a couple of people. Sammy's back. Okay, 12:30. We are scheduled to go a little bit long, so I'm going to go ahead and get started. Despite the fact some people are not here, I'll keep taking roll as we go. So our first presenter today is Audra Saint-Ange. Hello, Saint-Ange.
Hi.
There she is, Audra Saint-Ange. I'm going to hand over control to you, and you can put your PowerPoint up, okay?
Okay.
Here we go, and you're on. Go ahead.
Can you see that okay?
It looks good.
Okay. So today I'm going to be talking about gender differences in sport-related concussions. So before we get started, I'm going to be giving you guys a little bit of background information. So a concussion is a type of traumatic brain injury that occurs from an object hitting your head or jolting your head that results in your head and brain moving rapidly back and forth. The acceleration of the brain hitting the wall of your skull can cause bruising, nerve damage, and swelling, and this overall is what results in you getting a concussion. Your frontal and your temporal lobes are the most susceptible to sustain the brunt of the force due to your frontal and temporal lobes being so close to your skull. When a concussion occurs, there is a cascade of neurochemical and neurometabolic events that occur, and these alter homeostasis. When a concussion occurs, it causes your neuronal and your axonal membranes to stretch. This stretching allows an influx of ions to move through the channels. As the ions move through the channels, this also allows multiple neurotransmitters to fire. Calcium ions also go into the cells. This causes the cells to swell. All of this causes a chemical imbalance, and this is one of the major reasons why people lose consciousness when they obtain a concussion, due to all the changes that occur in your brain so rapidly. So a sign is something that you see, and symptoms are something that you feel. Some of the signs of concussions that you will notice when someone has one is they will look very dazed and have like a confusing look on their face. You can notice personality changes, such as a person might be more irritable than normal. They will also not be able to recall events that occurred before hitting their head. Some symptoms that are part of having a concussion are the typical headache, nausea, having dizziness, vomiting, having some blurred vision, or not being able to look from like the bottom of your computer screen to the top. It'll change your vision. Having sensitivity to light and noise, having a lack of balance, and overall being tired. Symptoms usually resolve themselves within a week, but it can take up to usually 30 days to be fully recovered from a concussion, but these times can vary depending on the severity. So I don't know if anyone has heard about the IMPACT testing, but it stands for Immediate Post-Concussion Assessment and Cognitive Test. This is a computerized test that records your neurocognitive state by measuring your verbal memory, visual memory, symptoms, and brain processing speed. So this is a test that you would take at the beginning of one of your sports seasons. This gives your athletic trainer a baseline of all of your scores. So if you were to get a concussion during your season, you will take this test again. When you take this test again, it will see how far you moved from your baseline. And you keep taking this test to see how close you get back to your baseline scores. When you go back to your baseline scores, that's when you can return to play. On the bottom left-hand side, here's an image from one of the tests. So you could be shown an image like this at one point during the test, and then you will be asked again later throughout the exam which picture was the same as the picture shown before, and you have to remember which picture was shown. The same with the image on the right. Numbers will correspond to the shapes, so you'll be shown a shape at some point during the test, and you have to remember what number corresponded with that shape. So if you got a concussion today from being in a car accident and you were brought into the emergency room, you'd typically be given a CT scan or an MRI. This would be to ensure that there is no brain bleeds or swelling. There's a new type of way to identify if you have a concussion, and that is through a blood draw. And this is 90% accurate in diagnosing a concussion. It is found that people who have sustained a concussion have a different pattern of metabolites in their blood. There is also the presence of the proteins UCHL1 and GFAP. The best way to recover from a concussion is to sleep. Put down your phone, don't watch TV, and lay in a dark room with less noise. A cold compress is also good to apply to your head every 10 minutes for a couple of hours. You should avoid taking pain relievers like ibuprofen and aspirin because they may increase the risk of bleeding. The effects of concussions are common to resolve themselves after a month, but there can be long-term effects. Long-term effects basically are most likely to occur if you sustain multiple concussions within your sport career or your lifetime. And if you have never returned to your baseline levels, or you return to play too quickly without recovering from your first concussion and sustaining a second concussion, so you're trying to recover from both at the same time. Aaron Hernandez is a famous football player that brought long-term effects of concussions to researchers' attention. His autopsy revealed that he had stage 3 chronic traumatic encephalopathy, which occurs after receiving multiple concussions. Chronic traumatic encephalopathy is associated with personality changes, memory disturbances, speech abnormalities, and can only be diagnosed from an autopsy. This is one of the reasons why Aaron Hernandez may have committed his murder, was due to the personality changes he had after having so many concussions during his time. Depression and psychiatric problems, along with insomnia and insensitivities, have also been reported by athletes that have been retired and their loved ones. The NCAA has made it their mission to decrease how many concussions there are within high school and collegiate athletes. They make sure to get coaches and their players all the training that they need so that they can be safe. In a study done by McAllister, Dietrich, and colleagues, they found that female athletes had a better understanding of what a concussion was, what symptoms came along with a concussion, and why it's important to report a concussion than male athletes. Because they found that female athletes knew more about concussions than males, they wanted to see who would be more likely to report them, males or females. They found that female athletes were more likely than male athletes to report concussions than the males. But when they asked both athletes why they didn't want to report having a concussion, they all had the same top 3 answers, which were they didn't want to miss out on a game, they didn't want to let their team down, or they didn't want to lose playing time. This study had 1,000 participants, and out of the 1,000 participants, 52% of them reported that they had symptoms during a game and did not report them. Leah Frommer and colleagues did a 2-year study looking at high school athletes. For 2 years, they looked at the difference between male and female concussion symptoms. After the 2 years was up, they found that male athletes were mostly reporting amnesia, confusion, and disorientation. Female athletes were reporting sensitivity to light, sensitivity to noise, drowsiness, and feeling emotional. Females also reported having a higher level of anxiety. Although there was a slight difference in the symptoms between the males and females, it was not a great significance in the study. So to be able to return to play after receiving a concussion in your sport, there's different protocols, but you have to go back to your baseline score from the impact test or close to your baseline score. You also have to have no symptoms, and you may also have to do a fitness test to ensure that if you were to go for a light jog, you wouldn't get a headache again. John Baker and colleagues looked at the difference in recovery times between the two genders. They found that females tended to take longer than men to recover from concussions. They found that female athletes had an average recovery time of 24 days, and male athletes had an overall recovery time of 20 days. Since there was a difference between the male and female athletes in the recovery time, Sarah Stone and her colleagues wanted to see if there was any difference in sports that both genders played, such as hockey, soccer, and basketball. She found in her study that male soccer players took an average of 22 days. Male soccer players took an average of 22 days, and female athletes took an average of 28 days to recover from their concussions. They also found that female hockey players took an average of 24 days, while male hockey players took an average of 21 days to recover. However, they did have an interesting finding when they looked at basketball. They found that male basketball players' recovery time was 22 days from their concussions, while female athletes took an average of 20 days to recover from theirs. Although there was the slight difference with basketball, overall it is found that female athletes tend to take longer than male athletes to recover from concussions. So because female athletes tend to take longer to recover from concussions and have slightly different symptoms than males, I wanted to look at why this could be. One of the ideas behind this difference in recovery times and symptoms in female athletes and male athletes is females using contraceptives. Virginia Gallagher and her colleagues found that female athletes that took contraceptives had more severe symptoms than those females that did not take contraceptives. When she looked at the difference in recovery times, she did not find a difference, however. Another interesting thing that I found was that females may be more likely than men to get a concussion due to women typically having weaker necks than men, and women also have a greater head-to-neck acceleration upon impact. The male corpus callosum also has a larger cross-sectional area, and that cross-sectional area contains large fibers. Females, on the other hand, do not have that large cross-sectional area and also do not have the large fibers. For those of you that don't know, the corpus callosum connects the two hemispheres and is severely strained when you get a concussion. Males typically use the lateral sides of their brain matter when they complete a task, and females typically use both hemispheres when they complete tasks. Due to this, females use both hemispheres to complete tasks, so when they obtain a concussion, their corpus callosum will not function properly. This may be a reason why females may have more severe symptoms and may have longer recovery times than males. So to conclude, it was found that female athletes had an overall better concussion knowledge than male athletes. Female athletes were also more likely to report their concussions than male athletes. Female athletes were seen to have more severe symptoms. Some of that can be attributed to their use of contraceptives. Female athletes overall had longer recovery times than males, and it is seen that males and females also have a slight difference in their brain anatomy. These are my references. Does anyone have any questions?
I have a quick question. You said that males who have had concussions report amnesia, confusion, and disorientation. How can you tell if a teenage male is feeling amnesia, confusion, or disorientation? Isn't that their normal state?
Probably.
Sorry, bad joke. So in terms of high school athletics, are there rules now that are trying to decrease the amount of concussions people get?
I know for my county, all soccer players now have to wear what's called a full 90, which is like a concussion band that goes around your head to protect from like heading the ball or heading someone else. So I know that's one of the ways that they've tried to lower having concussions in high school, but I'm not sure about anything else.
Does that change the way you head the ball? Does it interfere with the gameplay?
I don't think it necessarily interferes with the gameplay, but it makes it so it's hitting like a cushion before it's hitting your head, so it lessens the impact.
Okay. Any other questions? Okay, good. I'm going to take it back over and if I can, withdraw. Okay, so our next speaker, if I'm not wrong, and I never am, yes I am actually. I believe our next speaker is Sam Robinson. Sam, can you bring yourself up? There's Sammy. Mind if I call you Sammy? I like the word Sammy.
You can call me whatever you want.
Just don't call me late to dinner. Oh, that was bad. Okay, so I'm going to go ahead and hand it over to Sam Robinson and make you the co-host, and then you can share your PowerPoint. Go ahead.
So I did my review paper on experimental research on retinal ganglionic cells. So retinal ganglionic cells are neurons located in the retina. They relay signals from photoreceptors to the brain for processing. They are essentially responsible for your vision. Retinal ganglionic cells can be damaged and harmed in many ways, and many such ways could be as neurodegenerative diseases, traumatic injuries, metabolic disorders, and inflammation. Several examples could be diabetes, retinal ischemia, age-related macular degeneration, Parkinson's, schizophrenia, and excessive damage to these cells will result in blindness. Now, in terms of experimental research, there's been mainly three modes of treatment that have been used, and that's pharmacological, stem cell replacement, and gene therapy. Pharmacological and gene therapy have seem to be the most common and maybe the more successful of the three. But stem cell replacement therapy has also been pretty important, but also limited in what it has done, I'd say. So to start off the treatments, we're starting with pharmacological treatment. And I did more than three of these studies, but I've included the three that are more unique, I would say. And the first one, starting off with the methylene blue study. Methylene blue is known as an antioxidant. And the question of the researcher was, can progressive RGC death be stopped after an optic nerve transection, which is the optic nerve is just being severed. So the intravitreal injection of methylene blue after the complete optic nerve transection was done. And what these researchers were also looking for was the amount of GAP43 positive retinal ganglionic cells. GAP43 is a regenerative marker. So basically, if a cell is GAP43 positive, it has regenerative properties. It's being regenerated.
A quick question. What species is this in?
Oh, yeah. So the animal models, the picture in the background is of a rat, but all the animal models are mostly rodents. So rabbits, mice, rats. Very rare to see a human study. I think I've only come across 2 or 3 that I've seen, and it's only in eyeballs that have been like frozen or you know, things like that. Yeah, it's been post mortem, if you'd like to say that way.
Right. You couldn't do these studies in a live human.
Yeah, exactly. Well, one study was, and it was in Parkinson's and schizophrenic patients, but it wasn't an invasive maneuver really. It was intravitreal injections, but that was their medicine. So it's not anything like this, where it's experimental. So, okay, so the results. So basically you can see the 3 bars with stars over them. Those are significantly different, and those are vastly different than the other 3. The 2 NS over them are not significant. So you can see there's kind of an optimal range. 1 star is indicating like a p-value of 0.05, less than 0.05. 2 stars is a p-value less than 0.001. And then the 8 micrograms of methylene blue is roughly at a p-value less than 0.001. Methylene blue promoted the growth of axon-like processes, but I'll add this in now because it'll come up later. These processes are very short and small. They are not grown out very big, but you can see that there is an increase in RGC survival by 18.7, 22.7, and 30.3% respectively for these 3 that have significant differences, which is a big difference compared to these others for RGC survival. Now, the following study is really unique because this is the only study that I have found that is a non-invasive study. There is no needles, no treatment method that is invasive. So previous studies have kind of illustrated that this BDNF level, which BDNF is brain-derived neurotrophic factor. And what this does is in eyes that are exotomized, which is exotomized just means axons are being severed. So aerobic exercise promotes brain-derived neurotrophic factor levels in exotomized eyes. So what they are studying is, can BDNF levels save RGC survival after an optic nerve transection? The optic nerve transection was only performed in 1 eye, with the right eye serving as a control. The rats were exercised before and after the transection with 2 groups. One group had 2 weeks of exercise, which was 5 days a week at 5 to 6 meters per minute for 2 weeks before and 2 weeks after. The other group was 3 weeks beforehand and 1 week after of the same exercise and time and rate. The results. So BDNF upregulation was shown to have a significant difference in RGC survival. It was observed at the 7th and 14th day of the post-exotomy. And then as a kind of as a control to illustrate that BDNF is the cause of this, they purposely downregulated it, and RGC survival massively downgraded it. A lot of cells died. It's kind of showing that this aerobic exercise that upregulated BDNF was creating this delay in death. Now, the final pharmacological study here is melatonin. And I'm sure most of you know what melatonin is. It's a relaxing agent. It's natural in our body. And it also can be an antioxidant, an anti-inflammatory, and an anti-apoptic agent. So what they want to test, and this is now changing from physical trauma to a different type of trauma in oxidative stress. Diseases such as glaucoma and age-related macular degeneration can occur through oxidative stress. So this is pretty pertinent to human beings. In the results, you will see that melatonin actually protects RGCs very well from oxidative stress. In the top graph, you will see that that is the percent of RGC life, the percentage of RGCs that survive. The white bar is the control, the black bar is the oxidative agents, and the gray bar is the oxidative agents and melatonin. On the bottom graph, that is your cell death, and that is showing your control, your black bar, which is your oxidative agents, your control, which is just melatonin, and then your glutamate and your BSO with melatonin, and it's showing that it is protecting the RGC cells, RGCs. The second mode of treatment is stem cell therapy, and the one study I have included here is mesenchymal stem cells. And mesenchymal stem cells are from tissues or bone marrow, and these cells were found to have neuroprotective properties. And the studies done with prior were on optic nerve crushes and glaucoma. And what essentially they did is they injected these mesenchymal stem cells and found that there was an indirect relationship, or not indirect relationship, an indirect neuroprotective ability. The mesenchymal stem cells didn't protect the retinal ganglionic cells. It was the factors that mesenchymal stem cells were secreting. They were secreting these factors called platelet-derived growth factors, which is like a whole family. There's several factors in this group, but the factor that was looked at here was platelet-derived growth factor AA, and platelet-derived growth factor AA was shown to yield specifically neuroprotective behaviors from the mesenchymal stem cells only, though. And the following page here, the graph on the bottom right is showing what PDGF-AA looks like being through direct intravitreal injection. So this is not through mesenchymal stem cells. They are now doing it intravitreally to see if it's just PDGF-AA that is allowing for this protection to occur, and it's not the case. So, and on the top right picture, there is enhanced green fluorescent protein lines used. Now these lines indicate where receptors are. So with these lines, you are seeing PDGF-A receptors, which are broad receptors for many of the factors in that family. And while this study focuses on PDGF-AA as a factor alone, it's the combination of all the factors that are secreted from the stem cell that create a good neuroprotective agent, and not just PDGF-AA. And just for information purposes, in the graph, the other two agents, the blue bar, those are other neuroprotective agents. They are known as BDNF and CNTF. And now on to gene therapy. So with this one's by far seen the most success in terms of generating and protecting retinal ganglionic cells, as well as generating axons. It's by far the best method in what they do, and has definitely seen the most progress advance forward. And the disclaimer is that this is still a very open research field, and you can't really say there's been any real breakthroughs, but this is the most promising by far. So in this study, they were removing non-muscle myosin 2 from retinal ganglionic cells. And actually a problem with trying to regenerate and protect neurons to begin with, overall, not just retinal ganglionic cells, is the environment they sit in is very inhibitory and how do you want to word this? Restrictive. So they are not easy to get to because of all these molecules and agents that are floating around in this environment. So what in this study, what they aim to do is to reduce that inhibitory environment to a way in which RGCs and axons can essentially grow without restrictions, and that's exactly what happened. They knock down non-muscle myosin 2A and 2B, and they do this right before an optic nerve crush, which would then, cause a lot of damage. And again, another problem, like I said earlier, with neurons, in general, when you're regenerating axons, they do not do what you are trying to get them to do. They might make it to the optic nerve hole, or they might make it to the optic chasm, and they might start making U-turns or making all these wacky, weird, indirect, convoluted directions that aren't actually helping anything. So that's one of the problems with regenerating axons to begin with. So the results. So the results are very unique because the number of RGCs vastly improved compared to most of these other studies. The axon extensions regenerate at one of the highest rates and one of the most efficient rates that any study has had. The average length in just the initial study done was around 2 millimeters, which is a lot compared to what I was talking about earlier. What I was talking about earlier in the methylene blue study is that these processes were just merely sticking off the cell and maybe not much more, very small. We're talking about 2 millimeters off of the RGC cells now, the RGCs. Now they took this study a step further, and they did a complementation with a pharmacological agent known as Lin-28A. They overexpressed it. And when they did this, they got even better results than they did beforehand. When they did this, the longest axon they created was 3.5 millimeters long, with 3 millimeters being average. That's another millimeter added on to the initial study with just gene therapy. This second edition of the study includes a pharmacological aspect into it as well. And then the final gene therapy study in here is molar glia to neuron conversion by CRISPR-Cas9. And what they did here is similar to the last study. They did the knockdown of polypyrimidine track binding protein. And this was shown in prior studies that when a knockdown of polypyrimidine track binding protein was done, they were able to convert other cells into neurons. And this was done, the prior studies were done with rats. And what they did is they did that knockdown, and then they were able to convert fibroblasts and I believe microglia to neurons in rats. So this study is an extension of prior studies that have already proven that PTB-P1 knockdown can influence growth and regeneration. So that is what they do. And they do this in an interesting way, and it gets very complex, but essentially they get this done and they use a special type of mice. They're called Cree driver line mice. And these mice are transgenic mice that are able to interact very interestingly in the experiment. You have more control over what happens in terms of a neuron sense. You can choose where these like reactions occur, where these molar glia are converted to neurons, so you can watch it essentially. Which in the past studies where they have not discovered this, they didn't have these Cree driver line mice that you were able to see what was happening. So this experiment was actually occurring successfully, but they were not able to spot it. I didn't include pictures because there's a lot of them and they can get very kind of hard to explain. But in prior experiments, basically what was happening is they were actually converting molar glia cells to neurons and RGCs. They were doing the conversions, but they weren't finding the conversions. They weren't finding the new neurons. They weren't marking them properly. And this experiment nailed it on perfectly, where they were able to mark and find every single one they converted, and then they were able to report on it. And what they reported on was that they were able to convert, they were able to essentially convert these molar glia cells into neurons, and obviously specifically RGC cells, but all types of RGC cells. It wasn't just one kind, it was a variety of RGCs, which is very good because then, a variety is always better with these cells. And there are certain variants of RGCs that are very hard to kill, basically. There are RGC cells, RGCs called introphotoreceptive retinal ganglionic cells. And these cells I'm talking about right now do not die, essentially. They regenerate really fast, but they're not common. So the fact that you are able to do this conversion and potentially get some of those cells is really good. And to overall conclude this is that gene therapy, it looks the most promising with the complementation of a pharmacological aspect and potentially stem cells, but the pharmacological aspect certainly kind of adds into that gene therapy. And as we saw in the first gene therapy study, the complementation made it an even better study. It made it an even better headline.
Okay, good. Looking for questions out there. Who's got a question for me? I've got one, but I'm going to let the group go first. Vanessa Gordon, why benefits does the gene therapy, what benefits, Vanessa, could you rewrite that? I mean, what? Okay, what benefits does the gene therapy have on the cells, I guess?
Okay, so well, the gene therapy, like the main point of it is, I described it earlier. Maybe I talked too fast. the environment in which these neurons sit on, especially these retinal ganglionic cells, it's like in a very inhibitory environment. So in other cells, maybe it's easier to use these pharmacological and stem cell agents where the secretions and these factors improve the life. But in this environment of RGC cells and any neuron really, it's really inhibitory and restrictive. So the gene therapy, what it does is it takes away these elements of restrictive capabilities. So the gene knockdowns are taking away restrictive elements essentially. So the knockdown of myosin and the knockdown of PTBP1, they are making it easier for the RGCs to regenerate and grow the axons, which they weren't able to do before the knockdown. A knockdown is just the gene is losing its function. You're taking the function away from the gene, so that gene can no longer affect these cells.
Okay, good. Another question. Do you know how melatonin helps with oxidative stress?
I don't know how explicitly it does, but I know there are reports out there that have proven that it's an antioxidant. And that's why they ended up doing this study, is because it's a known antioxidant and a known anti-inflammatory and anti-apoptic agent. So they use this to see if it would affect RGC cells. What I would say is that it's really easy to think of this stuff like a drastic change. So even though we saw a high significance level in that study, these could still be minor changes where it's like, well, the RGCs didn't all just die off, but it delayed their death, which is really what a lot of this research is. Because like I said, until the gene therapy with the pharmacological agents, you're really just delaying the death of these cells. Because when you have a problem like an optic nerve transection, or you have schizophrenia, or any of these kind of degenerative diseases, they're gonna kill the cells regardless. It's just whether you can slow them down or not. And that's what these studies are at right now.
Okay, I've got a quick question. So I know you said this at the beginning, but I lost track of it. What causes the damage? You said Parkinson's and some other neurodegenerative diseases. Can like accidents cause this as well, or trauma?
Yeah, 100%. They're actually, these cells are like, just like any other neuron, they're very sensitive. So when you sustain injuries or have these diseases, they put either pressure or like, so a really good example is diabetes. Diabetes puts a lot of pressure on the inside of the eye. So you're pressuring those cells underneath those layers. And like glaucoma, that's exactly what glaucoma is. If you know what that is. Glaucoma is a raised intraocular pressure. So the inner chamber of your eye has too much pressure, and it's pushing on these cells that are, it's squeezing the cells basically. These neurons.
Okay, good. We're about at the end of your time, so let's call it a day and move on to our next person. Thank you very much, Sam Robinson. Very good job. Okay, so our next person is Celine Ramos. I don't know why, but I always have to say it that way. It just seems more impressive.
Thanks. I appreciate it.
Do you? I don't know. All right, I'm just pulling you up here on the big board so I can hand over to you.
Okay.
To Celine. Why am I not seeing you? Hang on a second. What's your name? Celine, S-A.
Yeah, S-A-L-E-E-N.
I'm not seeing it here. Oh, there it is. Oh, I see. See, on my list over here, I've got all the names in alphabetical order, but because your video is on and nobody else's, you went to the top.
Oh,
That's what happened.
my bad.
No, it's not your fault. I'm still learning Zoom here a year later. Okay, so you are the co-host, so you can go ahead and get started whenever you're ready.
Okay. Let's see. Can you see my screen?
Yep.
Present. Okay, so my research topic was to focus on how air pollution affects children's cognitive development. And we're going to first start talking about cognition. So in a nutshell, cognition is the way a person processes and understands situations and informations in life, but a good way to break it down is Paget's theory of cognitive development. And the first step or stage is the sensory-motor stage. And in this stage, it's between ages 0 and 2. And infants in this stage, they understand the world around them through sensation, whether that's grasping on things, whether it's like grasping like the blanket next to them or their other hand, sucking on things too, like allows them to understand like how things like feel and the way things are shaped. They also understand the world through manipulating their environment, in the sense when a baby cries, the mother will come running, or whoever's caretaking of the child will come running to their defense. And in order to go from the first stage to the pre-operational stage, the child has to understand object performance. So when you play peekaboo with a baby, the baby thinks that you're gone once your hands cover your face until you remove your hands, and they think you magically appear again. So they have to understand that objects are still concrete and still there, even though they don't see them. So then in the pre-operational stage is from ages 2 to 7. And in this stage, they start understanding symbols, and they start using symbols in the sense that, like, if they see a smiley face, they know that means someone's happy, or if they see a sad face, they understand that that associates with sadness. And they also stay thinking egocentrically. So they have a hard time perceiving the way that you saw the situation from their way they saw the situation. And then the next stage is concrete operational stage, which they start thinking of thoughts more logically and organized, but it's still heavily concrete. And this is around the age of 7 to 11. And then from the formal stage is 12 years old and up. And now they're able to understand concepts abstractly. So they're able to think about ethical and moral situations, social and political issues, and understand that. So your cognition is responsible for a bunch of things. It's responsible for working memory, which is that memory in the back of your mind that holds information for 10 to 15 seconds until your brain realizes if it should go into long-term storage or if it should still stay in short-term memory. It's also responsible for attentiveness, to have the ability to focus on something and really stay tuned to that. It's responsible for problem solving, so you're able to think of the problem in your mind while coming up with different solutions and still have all of those scenarios still in your mind processing at the same time. And it's also responsible for learning, because without the 3 things that I just talked about, it's really hard for a child to comprehend things if in their working memory they've only had it for 2 seconds, and if they're not really focusing on material, and it's just hard to problem solve with none of that. So air pollution. We all know air pollution is pretty bad, and it's more severe in other areas. So like New York City is pretty bad, LA is pretty bad, major cities, because of where they are and all the fumes and vehicles and factories that are located near cities, compared to like say Blacksburg, which is a more rural setting. And in these toxic air particles, there's isophorone, which is found in paints and inks, which is exposed to children on a daily basis, since kids are constantly doing activities such as painting, or even found in like the paint on the walls that we use to paint our homes. And that causes dizziness and fatigue. Another particle is particulate matter, which is found from like construction sites, probably from like the fumes that are being emitted from there, which causes cardiovascular disease and asthma. And then the last 3 toxins are all from burning of fuel, gas, wood, and coal. So PAH is one molecule that stands for polycyclic aromatic hydrocarbons, and it causes cataracts, kidney and liver damage, and jaundice. And jaundice because your liver isn't being able to process and break down bilirubin, so you're getting that yellowness in the skin and mucosal layers. You have nitrogen dioxide, which causes asthma, and it increases your respiratory system to infection. And then you have carbon monoxide, which also lowers your immune system and increases your respiratory system sensitivity. And all of these airborne toxins are able to pass through your blood-brain barrier, which is your brain's natural defense from toxins. And so the way that these toxins get into your system is that you inhale them, they go down to your lungs, they're able to exchange with your capillary beds. Now they're in your bloodstream, which passes right through that blood-brain barrier and affecting the brain directly. So the people who are most at risk to these toxins are children, starting right from the first trimester of a fetus to about 9 years old. And the reason for this is because kids they have higher respiration rates, so they're breathing in a lot more oxygen a lot faster than, say, adults. So they're just putting in more toxins into their system, and it travels right to their brain. So the most critical group is the first trimester all the way till after birth, till 3 years old. And that's because the brain's rapidly growing during this stage, and you're getting those building blocks and that foundation set up. So with like a house, if you have a bad foundation, it's going to crumble everything else. But that's why adolescence is least susceptible, because they already have a decent foundation to their home. So it'll only affect everything from that point on. And also children are more likely to be around these fumes more than adolescents, because adolescents are always constantly moving, while children are more or less stagnant in one area in a concentrated place. So prenatal exposure is a big thing too, because the toxins are able to get into the blood system and pass right through the placenta, which placenta a lot of the times helps keep things different from mom and the baby sometimes, but not with these toxins, since it passes right through. And it affects their adaptability, social skills, and functional communication down the road, which is really important since it helps with like their school and things like that. So if they can't communicate, they're not understanding processes that people are talking to them and trying to teach them. So learning becomes really difficult, and it's hard for their brain to comprehend those aspects. Some of the ways that these toxins affect the brain is through endocrine disruption, And it does this because the particles are basically, they're inhibiting less like nutrients and oxygen to get to the cells that need it. So therefore it's inhibiting the endocrine system from doing its job, since it's not getting fuel or anything to perform. And the endocrine system's one of the main functions is for growth and development. And if it can't perform growth and development, it's going to be a really hard time for the brain to grow and develop. Another way that toxins affect the brain is through direct gene toxicity, which is basically the toxins will go right into the DNA and break up the DNA fragments, damaging the DNA. So therefore you can't get transcription or translation occurring, you can't get proteins to carry out functions of cells, and therefore you're getting a lot more damage at the end too with that. So one type of air pollution is traffic related air pollution, which is basically from the burning of all the fuels in the air from cars and buses and trains and factories and industries. And in this study, they was mainly focusing on schools and how kids transported from home to school. And it varied upon a lot of different things, whether their socioeconomic status was allowing them to have a car so they could drive, or if it was just cheaper to walk, or if they were just closer to school so it made more sense to walk. And they found that walking was the worst for the children due to affecting their cognitive development, because since they're walking to school, they're probably walking a lot longer than, say, driving or taking the bus. So they're exposing themselves into all that air pollution. They already have high respiration rates, and if they're walking, they're probably increasing their heart rate, which is going to furthermore increase their respiration rate to try to get more oxygen in their system. So there's just that continuous battle of the toxins being around them. And also every school is a little different in the sense where they're located, because some schools are near busy highways, other schools have a lot of roadways near them, while other schools are more surrounded by trees and open fields. Or you might even have a construction zone right near your school or at the school that could be emitting harmful gases and toxins. And at the end, they found that it was decreasing their attentiveness and their math scores, which are good indicators of their cognitive development, since math scores, like, you have to learn math in order to do math in a sense. So the kids weren't necessarily absorbing all the material. They were less focused on the material at the same time. So it hinders them a lot, especially like in the future, since if they're doing bad in school, the more likelihood of them not to get into like a good college, into a good job, and to be like financially stable hurts them tremendously in life. And so along with outdoor air pollution is also found in the home, because air pollution just doesn't stop at the window or at your door. It's able to seep right through your crevices of your windows and doors and get into your home. There are certain paints that we use on the walls that release toxic particles into the air. If you're using cleaning products, there's a lot of harmful chemicals in there, and you're directly right over like the sink with the Ajax, smelling all that stuff, which probably isn't that great. And then the way we cook, so this study was kind of interesting because it talked about open fire cooking, which happens a lot, I guess, in third world countries, where it looks like this picture on the bottom left over here. And it kind of looks like a campfire like style cooking, where you make the fire, you put whatever on top to cook your food, and that releases a lot of carbon monoxide in the household, which 9 times out of 10 the children are staying in the household because they like to be close to mom and dad whenever they are around, and mom and dad are sometimes like mainly in the household. And then another thing that affects your home life is air quality. So if you have poor air quality due to dampness and condensation buildup in the home, you're increasing your chances of growing mold and microbes like on the wall. So then that will be embedded in the air as well. So that's getting inhaled just as much as if you were outdoors in that pollution. So then they found that it was affecting their verbal ability. So they weren't speaking as well long-term. They weren't comprehending language that great either. Their school readiness, so they weren't being necessarily well prepared since they aren't being able to communicate as well. Organized play plays that factor back in Pagot's theory of having logic and organized thought. They're not able to do that. And complex social behavior, they don't understand like group dynamics and abstract thought, so it's hard for them to engage in large groups. So luckily there's green spaces, and the idea of green spaces are places in large cities like Central Park would be to New York City, is that it's this massive area of grass and trees, and it's supposed to be a place for children to play or just for people to have recreational use. And in these green spaces, it promotes children to discover themselves and discover a new environment. It allows them to play, which also helps in growing and developing. It gives them a place to feel safe. It exposes them to healthy microbes, which is a good thing because healthy microbes help improve your immune system. So it can furthermore help you stay healthy. It allows them to focus on activities more since there's less noise around them distracting them. They can engage and focus on the activity itself. In the end, they found that it increases the child's mental and psychomotor development, and psychomotor development is just a fancy way of saying body control and fine movements. They also found that it decreased anxiety, depression, and stress, which was good because all those things are bad for a child's mental state and can really hinder them from doing well if they're focused on those things alone. It increases in their working memory and attentiveness, so they're able to hold the information longer and stay more focused. and it reduces the risk of sleep disturbances and stress. And sleep's really important, so it helps regulate your pineal gland to have that wakeful and nightful like sleep cycle. And stress, chronic stress is really bad, especially like for kids, because once you're stressed, your system is going to try to combat that, and it does it in a sense where you're gonna, once you're stressed, you activate your sympathetic nervous system, and therefore you increase your blood pressure, which is result from increased heart rate. And if that keeps happening for long term, you can start developing hypertension, which that's not good and has its own defects in that matter. So there is ways to improve your, a child's cognitive development with like more exposure to green spaces as much as possible. They also found that if you move to less polluted areas, like more rural settings, that it helps with their cognitive development. It doesn't change it necessarily a lot, but you can just see slight improvements over time. If you improve your household air quality by changing the way you cook, maybe use an electric stove instead of an open fire style method. If you change your cleaning products, if you to use like all natural, organic, safe compounds instead of really harsh chemicals. If you use like a dehumidifier to try to like make the house less humid, to make it less susceptible for mold and bacteria to grow on the walls and things like that. Also, if you play and interact in ways that directly focus on cognition, and this could be by playing like jigsaw puzzles, because it helps with that abstract idea of putting pieces together. If you play the game concentration, that helps with your working memory, because you have to remember everything that you and the other person have said on the list and to add another thing to the list. And chess is a good way of helping cognition, since it's a way to help develop problem solving, since you're trying to think of when your opponent's next move is going to be at every time. And then just to recap, cognition's the way the brain processes and understands material. There's a ton of air toxins in the air that we breathe in, whether that's PAH, carbon monoxide. It's hard to stay away from that. So we're always going to be exposed to it a little bit at a time. Children are most vulnerable because their brains are rapidly developing and they have higher respiration rates than adults. Air traffic pollution and poor air quality have negative effects on cognition, which we saw in the past slides. Prenatal fetuses can be exposed to toxic pollution because the toxins can travel right through the placenta, affecting their brain. Green spaces help improve cognition, and making those simple changes into your lifestyle, such as the way you cook, clean, use paint and stuff like that, can help improve brain development. And then that's my resources. Any questions?
Okay, I'm going to throw it open to the floor. Anyone with a question? For Celine. That's the problem with doing a great talk. There are no questions. It's just, this topic was so well covered.
Thanks.
I have a question. So you said something about hypertension. Can you give me an explanation of how hypertension leads to congestive heart failure? No, I'm just
I think that's the wrong class.
That was a different class. That's a different class. I know you can. I know you can.
I think so.
Okay, so your time's up anyway. So let's, oh, wait, here's a question. Vanessa Gordon. Do you think due to the environment becoming more and more industrial, cognitive development in children is going to get worse?
Wait, what was the question? I'm sorry.
Because the environment is becoming more and more industrial, do you think that cognitive development in children is going to get worse?
Oh, for sure. Yeah, and like the fact that people are continuously moving to larger cities, it's only going to get worse, because mass population in a small area, sharing all the same air, it's not going to get any better, I don't think.
I have to say, though, as someone who was born just after the baby boomer generation, I'm like the next generation, We grew up with lead.
Yeah, that's true.
All lead,
You're fine.
and the gasoline. So I'm a lot dumber than I should be. I think you guys are all smarter than me because you didn't grow up with that. So good for you.
But we grew up with phones, so I don't know.
You grew up with what? Phones?
Phones, yeah.
Yes,
I don't know.
that'll warp your brain as well. Okay, so we're gonna let you go so we
Okay.
can move on to our last speaker today, who is Nick Putney. Bring your face up, Dr. Putney.
Hi. All right. Can you see
There he
me?
is.
All right.
Yay, Nick.
Can you hear me too?
I can hear you. You sound good.
Cool. Thanks.
So I'm gonna make you co-host,
All right.
and you're now co-host, so you can go ahead and get started whenever you're ready.
Okay. Let me do this. Hmm. Are you seeing the right thing?
Let's see. Yep, beta 2
Okay.
adrenergic receptor.
Yep. Okay, cool. All right, so hello. My presentation is about the beta-2 adrenergic receptor and its significance in cancer progression and treatment. So during this, I hope to answer 4 questions. The first is, what are adrenergic receptors? Next, why are beta-2 adrenergic receptors important in cancer? Then, what are the effects of stimulating or inhibiting beta-2 adrenergic receptors by pharmacological means? And then lastly, by what mechanisms do beta-2 adrenergic receptors function, particularly in the context of cancer? All right, so the first question, what are adrenergic receptors? They are considered G protein coupled receptors that are stimulated by certain catecholamines like epinephrine and norepinephrine, or adrenaline and noradrenaline. These adrenergic receptors are broken down into first alpha and beta adrenergic receptors, and then further broken down into alpha 1 through 2 ARs and beta 1, 2, and 3 ARs. Historically, these receptors have been studied for their potential to treat heart and muscle problems. So a common drug are beta blockers that inhibit the function of the beta adrenergic receptors and reduce heart rate. Yeah. So before I move on and talk more about the beta-2 adrenergic receptor, I thought it'd be good to first talk about the cancer progression process. Cancer is a disease that affects lots of cellular processes. Pretty obvious statement. And it requires quite a bit of cellular hijacking in order to survive. First, it needs to be able to evade normal apoptotic signals that would just normally kill the cancer cells. And it's because the cancer cells want to spread uncontrollably. They want to survive. Also, cancer cells, as they are growing so much, need adequate oxygen and nutrients. And this is usually achieved through angiogenesis, or the creation of new blood vessels, which supplies the oxygen nutrients through the blood and allows the tumor to grow. And then also, the cancer, it wants to spread. It needs to get into the bloodstream in order to spread to other areas and completely take over the body. One method it does this is through a process called an epithelial to mesenchymal transition, where normal epithelial cells lose their polarity and therefore adhesive ability and break away from other cells and into the bloodstream. Okay. So why are people looking at the beta-2 adrenergic receptor in particular in terms of its effects on cancer? First, it has been in many studies to show to be a predictor of outcomes, or at least it's differentially expressed depending on how severe the cancer is. So here's one study that kind of looked at this, and the study analyzed tumor samples from oral squamous cell carcinoma, which is like mouth cancer, or various cancers of the mouths that affect squamous cells. Um, and they looked at them for expression of beta anginergic receptors. So in this experiment, they probed the anginergic receptor. They ended up looking at all of them, although I'll just be talking about the beta 2, but they probed it with antibodies that marked the receptor, and then attached secondary antibodies to those antibodies, which allow them to be visualized, and therefore you can see where these beta 2 anginergic receptors are. And it was found that beta 2 anginergic receptor expression was much higher in cancerous cells compared to the surrounding tissue, or even the just kind of normal non-cancerous tissue. Also, they found that low expression of the beta 2 AR correlated with improved survival rates, and yeah, improved 3 and 5 year survival rates, which is what they looked at. So again, the idea is if you you might be able to get some idea of the severity of somebody's cancer just by looking at the expression of the receptor of the beta 2 anginergic receptor. Another study which looked to answer a similar problem or answer a similar question looked at gene expression data taken from TCGA, the Cancer Genome Atlas, and ICGC, which are two databases that have gene expression data from a variety of cancer types. The researchers found that beta 2 AR was differentially expressed in different cancer stages, with higher expression of the receptor in stages 3 and 4 compared to stages 1 and 2. And over here, you kind of, for those unfamiliar, shows what each stage of cancer indicates, with lower stage being the cancer is less progressed, and stage 4 being just full-blown metastatic cancer, where it's kind of spread everywhere. To better understand what I said actually means, I thought it might be good to go over a little bit about how the researchers um, or how the data was generated that they looked at and what it actually means. So RNA sequencing or RNA-seq is a technique that is used to quantify all the transcripts in a sample. The RNA, which is what composes the transcripts, is an indicator of gene expression as by counting the number of transcripts in a sample, you can see how many times that gene was transcribed. Yeah, and therefore more transcripts of a gene indicate greater gene expression. And the data from this RNA-seq is reported as a simple numeric value for each gene of interest, which corresponds to the number of times the gene was transcribed. So in the case of the past experiment, it's just saying that the gene that is coding for the beta 2 anginergic receptor, the B2AR gene, um, is significantly higher. It's transcribed significantly more times in the higher stage cancer group. Okay, so on to the question of what happens with pharmacological stimulation and inhibition of the beta 2 anginergic receptors. Again, I'm going to go over a few studies that explore this question. The main class of drug used for this are, at least to inhibit them, are beta blockers, which are beta anginergic receptor blockers. They inhibit the function of them. One study looked at the effects of 3 different beta blockers: atenolol, which is a beta 1 anginergic receptor blocker, which inhibits the function of this receptor; ICI 118551, which inhibits the beta 2 anginergic receptor; and propranolol, which is a non-selective beta blocker, meaning that it blocks all 3, beta 1, beta 2, beta 3 adrenergic receptors, inhibits the function of all of them. So they conducted an MTT assay, which allows the researchers to quantify cell viability, cell proliferation, and cytotoxicity in cells. And they determined that ICI 118511, which was the drug that blocked activity of the beta 2 anginergic receptor, to be the most cytotoxic, and had the most significant impact on reducing cell proliferation. And this was followed by propranolol, which blocked both the beta 2 and beta 1 receptor, and then atenolol, which only blocked the beta 1 receptor. This suggests that the beta 2 AR plays a more significant role in cell proliferation in cancer compared to the beta 1 angiogenic receptor. Onto another study. This time they looked at the same beta blockers just mentioned, but this time it was on colorectal cancer cells, and they used flow cytometry, which a technique I don't quite grasp what it's doing, but from my understanding is it allows you to measure properties of cells, like the size of cells, um, how many cells there are, what stage of the cell cycle they're in, kind of, and so forth.
Yeah, basically you take your cells and you run them through, put them in a liquid and run them through this tube, and you can look at individual cells and count which ones have different characteristics. So it's like sorting and counting. It's really cool.
Okay, thank you. So yeah, they quantified cell viability and stages of the cell cycle. They found that propranolol and ICI reduced cell viability, which is similar to what you'd expect from the previous study, because both of these in some way reduce beta 2 angiogenic receptor function. In addition, they also induce cell cycle arrest at the G1 phase, which means that all the cells just in G1 phase stopped and they would not go on to the S phase, the synthesis phase. And it also induced apoptosis, or cell death. This suggests that blocking beta 2 angiogenic receptor could prevent cell proliferation in cancer. And the last study looking at beta blockers. So the previous two studies kind of showed or would suggest that the beta 2 angiogenic receptor kind of has pro-cancer properties, where by stimulation of it, you increase these pathways that promote cancer, and by inhibiting the function of the receptor, you could possibly prevent this. There has been a few studies to the contrary of that, and one such was one that looked at different beta 2 angiogenic receptor agonists and antagonists. This included propranolol, which looked at in the past two ones, which is a beta 2 angiogenic receptor antagonist, and salbutamol, which is an agonist, so it stimulates the receptor. The researchers introduced human breast cancer cells into mice and then injected them with these two drugs, and they found that salbutamol actually reduced tumor growth. So stimulation of the beta 2 angiogenic receptor reduced tumor growth, which is kind of opposite of what the previous research showed. And more so, the propranolol reversed the effect and actually promoted the growth of these tumors in the mice. So this would suggest that beta 2 AR activation actually can reduce tumor growth, and this just kind of shows that future research is necessary to more definitively show the effects of the beta 2 angiogenic receptor on cancer and cancer growth in particular. So on to the kind of the last question, and by what mechanisms does the beta 2 angiogenic receptor function? Because beta 2 angiogenic receptor is a GPCR, I thought it would be a good idea to kind of review GPCR signaling and just kind of the basics of it. Although first, here's a statistic that I thought was kind of cool. An estimated 34% of all the drugs that the FDA has approved target a member of the GPCR family. So it kind of shows just how widespread and important this class of receptors are. So there's two main, I guess, pathways or two main routes that kind of start GPCR signaling. One pathway leads to activation of, where am I? So this would be phospholipase C, or this is phospholipase C, PLC, by the G protein. G protein binds to it and activates it, which then splits PIP2, which I believe is some phospholipid, and it catalyzed the hydrolysis of this compound into DAG, or diglyceride, and IP3. And then IP3 binds to a IP3 gated calcium channel. And upon binding, it causes calcium to flood into the cytosol, which then activates PKC. And DAG also binds to this. And PKC, it affects many things, ranges from like protein synthesis to cell proliferation to I don't know. It's very kind of ubiquitous, PKC, the effects it has. And then the other pathway, little more simple, is increasing intracellular cyclic AMP. G protein binds to adenylene cyclase, and then adenylene cyclase catalyzes the production of cyclic AMP from ATP, and then this binds to inactive pKa and activating it. And similarly, it's pretty ubiquitous, activates and is involved in a lot of different signaling pathways. So onto some of the mechanisms that are more specific to beta-2 adrenergic receptor, and more specifically the pathways that are resultant from this receptor and that are involved in cancer progression. So as mentioned before, um, in most cases, stimulation of this receptor leads to cancer progression through cell proliferation, inhibition of apoptosis, angiogenesis, etc. Sorry, one second. Okay, so one way in which it causes some of these effects is through the activation of epidermal growth factor receptor. So it's kind of a roundabout way, but the idea is stimulation of the receptor, kind of follow along here, causes an increase in intracellular cyclic AMP, which activates pKa, it's kind of talked about before, which leads to the recruitment of a protein called beta arrestin, which arrestins in general are proteins that regulate G protein coupled receptor function. And this is recruited to the receptor and works to suppress the function. And then after this occurs, a non-receptor tyrosine kinase called CSRC binds to the beta arrestin, forming a complex, a beta arrestin CSRC complex. And this leads to CSRC binding to EGFR and catalyzing the phosphorylation of one of the tyrosines on the receptor. And then activation of epidermal growth factor receptor causes ERK and AKT signaling cascades, which is shown in a little more detail on the right. And those lead to increased cell proliferation, inhibition of apoptosis, angiogenesis, cell adhesion, migration, invasion, and kind of these things that previously mentioned contribute to cancer progression. Another pathway involved in beta-2 adrenergic receptor signaling involves the activation of a protein called exchange protein activated by adenylyl cyclase, which is down here. So it's the same idea. Beta-2 adrenergic receptor is stimulated by pharmacological or just natural means, which leads to a rise in intracellular cyclic AMP, which activates EPAC, which activates a protein called RAP1, which isn't shown here, and then activates BRAF, and then ERK1, 2, and then has a number of effects that promote cancer progression, including cell proliferation. And then just kind of in conclusion, beta-2 adrenergic receptors are G protein coupled receptors that can promote cancer progression through increased cell migration, cell proliferation, and cell survival through the promotion of ERK, AKT, and STAT3, which I didn't actually mention. Activation by beta-2 adrenergic receptor mediated mechanisms. Beta-2 adrenergic receptors have been shown to be indicators of cancer outcomes, with lower expression of the receptor indicating better outcomes. And beta-2 adrenergic receptor inhibitors have the potential to treat cancer. And just kind of lastly, Hopefully, future research will allow us to better understand the role of these receptors in the context of cancer, which would eventually lead to better cancer treatment, which is kind of the end goal of all this research. And then references and questions.
We're going to open it up to the floor. Okay, so Ruth has a question. Can you hear me? Nick, can you hear me?
Yeah.
Okay. Does the antagonist drug bind to the active site or change the conformation of the receptor? So is it competitive antagonist or non-competitive?
I'm really not sure.
That was a tough question. That's a good one from Ruth. Thank you. I do know the answer. It's a competitive antagonist. It binds the active site. That's propranolol. But that's a tough question.
Do you know if the other one does too?
Yeah, they're both.
Do you know if
both the agonist and the antagonist you were using, and it was it ICP something that's also competitive. It binds to
ICI, yeah.
Yeah.
Okay.
I just know that because I'm smart. Most people don't know that. Actually,
so a question for you: Do you know what?
What's that?
Do you know what difference that would make? In terms of like these pathways?
Right. Oops. Now there's a good question that I do not have an answer for. I could BS, but I'd rather send it back to you for more questions to you.
Okay.
But I'll give you a bonus point for asking a good question. Oh, Evans Cujo shows up. You're late but not missing. Would this antagonist drug only be in early treatment, or is it something that could also limit cancer growth? Ooh.
I didn't see much speculation in studies I read, but just with how it functions, I imagine it could be used at any stage, because it's just again, it would just be inhibiting pathways that are just generally involved in promoting cell proliferation and involved in the cancer progression process. So yeah, I think it could be involved in any kind of stage of the cancer process.
And just a little question. So is there a sense that these cancer cells, before they became cancerous, were expressing this beta-2 receptor, or does it just come up after they become cancerous? In other words, what are the controls?
And most of the body, there's very, very little to no expression of the beta-2 adrenergic receptor. So, but with the development of cancer, it's much higher, more highly expressed.
Yeah,
which would indicate that the cancer, for some reason, wants whatever this receptor gives it.
Right, that's what's interesting about it to me.
Or I guess it could be that the receptor in response.
Yeah, that's interesting that it comes up. It isn't just overexpressed in cells that already make it. It's coming up out of nowhere, and it's adding to the growth potential. That's interesting. Okay, I think that's about it for today. What did I want to say real quick? I can't remember. I had something I wanted to say to everyone in the class while you're still here. And that thing was, I can't remember. So anyway, I'll send you an email if I remember it. So we'll meet back here again on Thursday. And next week on Tuesday and Thursday, remember, it's finals week, but we're still meeting at the same class time next week because we've got more talks to do. Oh, and one more thing for Audra, Sam, Celine, and Nick. I'm going to send you an email right now with your grade, and included in that will be a Zoom link, and then just open the Zoom link. I'll get there. I'll only have to talk to people about a minute, so I'll get there pretty quickly, and then we'll talk about your grade. Okay, thanks a lot, people. Any questions? Comments? Okay, see you Thursday.